Hey guys, welcome back to my channel. Today I'll discuss about fertility preservation. So the name itself says we are preserving the fertility. Not only I'll discuss about females, I'll discuss about male as well. Okay, so basically, if someone is deciding about fertility preservation, that means they have some gonadotoxic, they're undergoing some gonadotoxic treatment, or else their ovaries are already being destroyed because of some sort of disease or medical reasons. Or if the female want to postpone her pregnancy, if she want to conceive later because of social reasons to achieve in her career in that way. Okay, so so indications for fertility preservation is first malignant disease. So we already know almost 50% patients are of cancer, and in this pre-pubertal girls are about 82,000. Okay, and so overall 5 year survival of that kid is 82%. So at some point of time she like to become pregnant, right? So for her, fertility preservation is needed. Okay, uh, and now, till date, there is no specific doses where which chemotherapy or radiotherapy at which we can prevent the ovarian failure. Okay, there is no that kind of data. Non-malignant conditions which I already discussed, like premature ovarian insufficiency, Turner's, Fragile X syndrome, family history of POI. Okay, other conditions like aplastic anemia, sickle cell disease, thalassemia. Okay, non-malignant conditions which have affecting the natural disease progress. Okay, bilateral benign ovarian tumors like teratomas. If we do surgery, then ovarian tissue will be removed in that conditions, and recurrent ovarian torsions also there is risk of premature ovarian failure. Okay. Advanced age, if the age is increasing, like if you see, only 20% of women are getting pregnant by 34 years of age. Okay, so with advanced age, the ovarian fertility gets declined. When do you do cryopreservation of embryos and oocytes? Okay, so first cryopreservation of the oocyte was done by Chen in 1986. Okay, then it's a mature oocytes are the largest cells of the human body, and they contain this delicate meiotic spindles. Okay, these mature oocytes are cryopreserved. You know, cryopreservation will keep good amount of coolness. Okay, this hardens the zona pellucida, and um, on fertilization there is adverse effects. Okay, so what they did is cryopreservation. They did there are two types of freezings. Okay, slow freezings and vitrification, that is rapid freezing. They started doing this thing. So slow freezing has improved the success rate. Okay. Um, if you see like 35 years old females, if they're getting this oocyte vitrification, the live birth rate is 60.5%. Okay. And one condition, if a girl or 13 years girl, okay, with some cancer, she want to preserve her fertility, so they does not respond to the medical stimulation. Okay. Um, in 13 years, okay, in fact they'll respond. 8 years kid, if she didn't attend puberty, so for them the medical stimulation, she doesn't respond to the medical stimulation. Okay, so the pre-pubertal girls, the only available fertility preservation is ovarian tissue freezing. What? Ovarian tissue freezing. In ovarian tissue freezing, there is no need of sperm requirement and all. Just you can use in pre-puberty. Live birth rate is also reported with this ovarian tissue preservation. So while planning for embryo or egg or anything cryopreservation, first we will consider about age, because younger the woman, the higher is the live birth rate. Okay. Mm, yeah. If we want to do oocyte or embryo preservation, then the chemotherapy, starting of that chemotherapy agents, like, way to delay the treatment by at least 10 to 12 days. Okay. So we should talk with the oncology team as well. They should agree for that. Okay, because in 10 to 12 days, there is chance of progression of disease in that way. Second thing is hormone sensitivity. Some cancers are sensitive to estrogen. So if you stimulate that ovary, then the cancer can increase. So low estrogen levels during ovarian stimulation should be is safer. Okay. For example, in case of estrogen receptor positive breast cancer, there is controlled ovarian stimulation with agents which block the estrogen production given in conjugation with gonadotropin. So you'll do gonadotropin and you'll give agents which block the estrogen production. Okay. For example, do give a combination of aromatase inhibitor, which is an estrogen blocker, and FSH, which is a gonadotropin for ovarian stimulation, to yield the good amount of oocytes in case of breast cancer, which are ER positive. Okay, this is the thing which they are telling about the uh, antagonist. There is a stimulation aromatase inhibitors for less estrogen. Second is ovarian tissue cryopreservation. In this thing, na, it's a unique approach. It is actually tissue is very suitable for prepubertal girls. Okay, there is no need of any stimulation, any thing like even the cancer patients they can start this treatment because immediately we'll do this surgery and you can go for chemotherapy followed by. Basically, we have ovary have tissue. We'll remove the tissue and we'll cryopreserve it. After this girl becomes adult and she's ready to get child, then we can use this ovarian tissue, which is cryopreserved. The first one was done in 1999 by Kutluk Okte. Okay. Mm, even now, they say that this ovarian tissue, which was cryopreserved, and after that, after the chemotherapy and all, we'll insert this inside the body. Now, this ovarian tissue also releases hormones. It has that, what do you say, endocrine activity also. Almost 95% cases, it was seen. Okay. Even though the Octay had done this, but first live birth by means of ovarian tissue is demonstrated by chemistry. Okay. Whole ovarian ovary preservation, like that means ovary total they'll remove and they'll cryopreserve it. But thing is, there is tissue ischemia. You'll remove whole ovary, the blood supply being blocked. So there will be tissue ischemia and loss of follicles is the main problem. And we can overcome this by reanastomosing the transplanted vesicle pedicle. We can reanastomose it, like uterine transplant, how we'll reanastomose the pedicle in that way. Okay. Disadvantages is malignancy can be again recur. Then there is cryo injury risk. Okay. That. Now coming to, I told we are freezing the ovarian tissue, right? That is known as vitrification, which is rapid, and there is slow freezing. Okay, slow freezing resulted in good number of live births. Um, See that we took the tissue, right? We need to transplant in the body. So there are two types of transplantations. One is orthotopic transplantation, other is heterotopic transplantation. Orthotopic transplantation means we'll keep near the ovary, like ovarian fossa or ovary, remaining ovary, or we'll keep in the broad ligament. That means it is near the anatomical situation location. Okay. So first was done by again Okti. So Okti is the one. He did the ovarian tissue thing, but the live birth rate was demonstrated by Dempsey. Then he felt like I need to do something that way. So first ovarian tissue transplantation was done by Octave. Okay, he kept this in pelvic peritoneum. Okay, mm, then yeah, there are several cases of live birth rates after transplantation, even after bilateral oophorectomy. Also, there is live birth rate. So they are confirming that because of this ovarian tissue only, the live birth rate is coming. Okay, heterotopic means it is this ovarian tissue is transplanted in area which is away from the normal location, like subcutaneous space of forearm, abdomen, anterior wall of abdomen, like peritoneum or rectus muscle. They'll keep there. Advantages is if this lady has so many operations, so many surgeries, if there is any pelvic adhesions, distorted anatomy, poor pelvic vasculature, okay, previous irradiation, then we can't open the abdomen and adhesiolize it and we'll keep over it. It is very difficult process. Then we can follow this heterotopic transplantation. By means of heterotopic transplantation, the live birth rate are small in number. Okay. Next is in vitro follicle maturation. That means, see, we everyone know that, even me, everyone, because our oocytes are being arrested in meiosis one, and it in every cycle, in every menses, this meiosis one is completed, and they're getting arrested in meiosis two. Okay, if we become if there is fertilization in that cycle, then our oocyte is released from meiosis two arrest, or else every cycle that meiosis 1 arrest is relieved, but meiosis 2 arrest is pertain. Okay, so I mean to say that we can do this in vitro follicle maturation. Like these two arrests we can relieve in vitro, or else mainly the follicle maturation requires this arrest from relief from the arrest of meiosis one. So we can relieve the follicle from meiosis one. So we'll take the primordial follicles, the largest pool of follicles. Okay, then we'll go in vitro maturation. Maturation means we'll relieve the follicle from meiosis one. Okay, in that way. This was done by newborn mice. Okay, mm, this was done by John Epic in newborn mice. Okay, then preantral follicles are being uh, collected, and from that follicles, if this is a follicle, there will be granulosa cells. Okay, that granulosa cell complexes are being removed. I mean, they are cultured, in fact. Okay, but successful pre-implantations are very low. Then he started using newborn mice, taking advantages of large way of follicular genesis in newborn mice. Okay, in that way. So these are all in studies. Okay. Then this Evelyn Treffler, developed the mature oocytes from the human ovarian cortical strips using four-step approach. Not that important. Coming to combination of ovarian tissue cryopreservation with ARTs. Okay. Um, this is very interesting. These Kawamura and other scientists has found that uh, in premature ovarian failure insufficiency, you know that all follicles are being arrested because immature and all. We can activate these immature follicles in them. Okay, they're saying that we can activate these immature follicles in them. Okay, mm, then. Yeah, how can we activate it? By disrupting the hypothalamus signaling and incubating the ovarian tissue with AKT stimulating drugs. Okay, like that resting follicles, if we give the stimulating drugs, then the growth of the resting follicles is being seen. Okay, and scientists like Arvis reviewed the records in the institution and concluded that oocyte aspiration just prior to ovarian tissue cryobanking yielded more oocytes because we are want to bank this ovarian tissue instead of cryopreservation, and when she want pregnancy then stimulating and removing the oocyte, less chance of getting pregnant. Once you remove at 8 years only you are removing, right? At that time only you do the oocyte aspiration and cryopreserve that as well. Then the better maturation rate is seen. Okay. This is a very important and interesting topic, that is menopause and premature ovarian failure. See, actually, some people says you if the woman, there are two women, okay, this woman had got removed both ovaries, and this woman got removed only one ovary, and third woman has both ovaries. Okay, so this woman will have late menopause compared to unilateral ovarectomy patients. Okay. Mm, and if you want to give a tissue cryopreservation for oophorectomy group, there is longer incubation period and fewer oocytes are being removed from these people. Okay. Mm, then frozen thawed ovarian tissue have a like for this woman who had undergone menopause, if we keep this ovarian tissue in them, this can prevent osteoporosis and menopause related disorders because I already told the ovarian tissues have that endocrine function as well. Okay, it can auto transplant in perimenopausal period, and these steroids can be maintained for years, and even after postmenopause, these steroids been maintained inside the body. Mm, some people, if this lady is some 46, she didn't get menopause. Okay, if this lady wanted to delay menopause also, mm, she doesn't want to consider, just she want to delay menopause. Then there is subcutaneous transplantation of ovaries, like ovarian strips. We can transplant in subcutaneously. It releases the endocrine, it releases the hormones and maintain that like perimenopausal state. Okay, there will be menopause will be delayed in this condition. Mm, Next is a potential complication resulting of tissue transplantation is pre-implantation ischemia is seen. Revascularization after transplant requires at least 5 days. Okay, sometimes the malignant cells been grafted. It's a serious concern. Hmm. See, if uh, for example, if a 26 years old girl, she got breast cancer. Okay, so she's getting that chemotherapy agents because of breast cancer. She's getting chemotherapy agents. We can protect her ovaries because she is a nulliparous, and we can protect her ovaries by giving GnRH agonist. This is a very interesting topic, but only thing is studies are being going on. It's not concluded that this is the best thing, but the reasons they gave properly. First thing is GnRH agonist. What it will do means, hmm, see, uh, if in a female, um FSH is coming and it's stimulating the follicles. Okay, we need to inhibit this FSH. How? By giving FSH from outside. By giving FSH like compounds from outside. That is only GnRH agonist. If you give GnRH agonist, then brain, the hypothalamus thinks, okay, we should not produce FSH. Then there will be follicles production will be low. Okay. So inhibition of FSH dependent accelerated follicular demise is done. That is the thing. Mm, so primordial follicles are 90%. So if you the FSH is producing daily, then more number of follicles are being produced. And if you give chemotherapy to this individual, then all the follicles will be killed. Okay. So in fact, some says that this gonadotropic like chemotherapeutic agents are there. Na, they also increase the follicular demise because chemotherapy agents create a low estrogen and inhibin levels. Okay, and results in more FSH, and more FSH increase in more follicles, and more follicles will be killed because of this chemotherapy agents. Okay, so finally we should make follicles number low. Okay, that is the thing first why we give GnRH agonists. Okay, second is even GnRH agonists which are giving external, which we are giving externally, it decreases the uterine perfusion. Okay, so it decreases the levels of FSH and LH that results in hypoestrogenic state. So and even the perfusion, the blood supply being decreased, so chemotherapy agents going to that side will be decreased. Last reason is um GnRH seems to be extra pituitary sites. Like GnRH agonist acts on the ovaries also, not only on the brain. Okay. In rat ovary, they saw that high affinity of these GnRH receptors are seen on granules and theca cells of ovary. Okay. So basically, GnRH treatment helpful to decrease the aromatase activity, so estrogen will be low, and it also decreases the synthesis of pregnenolone, progesterone by inhibiting the cholesterol side chain cleavage and 3-beta hydroxydehydrogenase enzymes. Mm, so, in vitro studies suggest that GnRH agonists may decrease the chemotherapy-induced granular cell damage, basically. Okay, how it decreases the damage? Um, because the GRH receptors expressed on a granular cell membrane, and there is decrease, there is, or else there is fail to increase the cyclic AMP, activation of ERK, P38 signaling in culture granular cells in response to GRS. Understood? So if the granular cells to grow and get mature follicle, they need this cyclic AMP, ERK, P38. But this GnRH agonist will decrease them so that mature follicle is not produced and uh, follicles are being preserved. Okay. Some says that GnRH agonists are effective in reducing the amenorrhea rates following chemotherapy. Okay. But regardless of this theory, evidence is supporting strong benefit is still lacking. So there are studies going on in this, but there are so many theories. That's it. Then future prospects of this fertility cryopreservation is there is an artificial ovary created. Like we'll create an ovary type of environment by keeping the ovarian tissue, and we'll create an artificial ovary. Okay. Only disadvantages of these things is introducing of malignant cells. Um, Then one approach is promoting the neovascularization, like promoting the pro-angiogenic growth factors. Okay. Mm, we should inhibit the apoptosis, proliferation of ovarian stromal cells with administration of sphingosine 1-phosphate. Okay, some uses the stem cells to produce follicles. Some use stem cells to produce oocytes. Okay, this is also been going on. Now we'll learn about FOXY 2018 journal focus on fertility cryopreservation. Okay, I hope the classes are being useful for you. These are all expected question topics in reproductive medicine entrance exams. Okay, so I'll give a quick revision. See, even boys and girls they need cryopreservation, which I already told, some cancers, endometriosis, in autoimmune disorders. Okay, premature ovarian insufficiency. If there is any transgender surgeries, if they want to preserve the ovary, they can do. Oocyte freezing can be done. Okay, oocyte freezing can be done. And chondroitin, I told na, GNRH analogs are being given to arrest in granular cells. Mm, then ovarian tissue, whole ovarian tissue can be cryopreserved. Then ovarian transposition, which I told orthotopic or heterotopic. Then gynecological surgeries, conservatively we can do that. Newer techniques I want to tell. Artificial OD, which I already told. Then newer photoprotective agents which are being used is imatinib, T3 hormone, granulocyte colony stimulating factor, AS101, AS101, and immunomodulators act on P13K, P10, AKT follicle activation pathway. These are photoprotective agents. In men, we can do in vitro spermatogenesis. Okay, we can take spermatogonia and we can in vitro we can form sperms. Okay, iolate stem cells are being used to produce oocyte and sperms. Then, semen cryopreservation is the only successful procedure. Ethically, we should consider because we should talk with oncologists and we should coordinate with the about the therapy. And second thing is, see, 8 years girl, if she want to cryopreserve, cost of that keeping that ovarian tissue, space constraints are also to be noted. Okay. Now we'll do few questions. Okay. We'll do few questions. We'll see how much we understood the topic. So, which of the following is considered the most established method for fertility preservation in women with a partner? So, women with a partner. So, what can be done? Oocyte we can take, sperm we can take. So, we can do embryo cryopreservation, right? Anyways, embryo cryopreservation can be done. Second question is, what is the primary surgical objective in fertility preservation surgery for epithelial ovarian cancer? So, in epithelial ovarian cancer, we should do fertility preservation surgery. What can we do? Preservation of uterus only, removal of visible tumor while retaining reproductive organs, complete removal of both ovaries, lymphadenectomy, and improve survival outcomes. So, basically, fertility preservation ovarian thing is, see, fertility preservation always depends upon the ovary. Okay, so removing the removal of visible tumor in the reproductive organs is the answer. Okay, then which chemotherapy agent is known to have highest gonadotropin? Vinblastine, cyclophosphamide, methotrexate, cisplatin. Answer is cyclophosphamide. Ovarian tissue cryopreservation is particularly recommended for, see, ovarian tissue cryopreservation. So you should know this thing also. Ovarian tissue cryopreservation means not the oocyte, not the follicles. We are doing the whole tissue. So in which people will do this? Prepubertal girl, young age woman. Yes. What is the major concern regarding auto-transplantation of ovarian tissue in cancer patient? Obviously, major concern is risk of introducing the malignant cells. Okay. Then, which fertility preservation option does not require gonadotropin stimulation? So, gonadotropin stimulation is not required in which condition, which I already told, in young girls will do. Yes, ovarian tissue cryopreservation. There is no need of gonadotropin stimulation. Which statement about general agonist administration during chemotherapy is true? So it is ineffective in preserving ovarian function. It has been shown to preserve cyclical menstruation. See, it is ineffective in preserving ovarian function. No, it is effective. It's not. It false. And it has been shown to preserve cyclical menstruation in survivors. It is only effective in case of radiotherapy. No, it is effective in chemotherapy drugs, right? So it is only method approved for fertility preservation. No, other methods are also there. So we learned one thing. No, is helpful to prevent amenorrhea in a patient with this thing. So it is to preserve the menstruation function. Okay. Then what is the main limitation of ovarian tissue cryopreservation in women older than 40? So older than 40, you're doing tissue preservation. What is the main limitation? Ethical concerns, reduced ovarian reserve due to age, high risk of ovarian cancer, and lack of surgical expertise. So, because of age, there will be less, na? Because 40, that's right. Which of the following is not recognized method of fertility preservation? Not recognized. Sperm cryopreservation, testicular tissue cryopreservation, gonadal shielding against radiation, hormonal contraceptive. OCP is not a fertility preservation, right? So that is the answer. In the context of fertility preservation, what is the significance of vitrification? It is a method of stimulation of ovulation. Vitrification is a method of stimulation of ovulation. No. It improves survival rate of frozen oocytes after thawing. Yes, right? Yeah, we learned this. And is used to detect malignant cells in the ovarian tissue. No. It's a surgical technique for ovarian tissue removal. No. After removal, you will do something. That is the thing. So